Welcome to the Satellite Symposium presented by Natera. This session will be moderated by Sofani Bunapradest from UCLA. Please stay tuned after the session talks for the panel discussion. If you would like to submit a question directly for the session moderator, please utilize the Q&A feature on the side panel of your screen. Enjoy the session.
Good afternoon. Welcome to the Natera Lunch Symposium. Today's the last day of CEoT, so I hope you guys learning a lot and having fun and be safe. So I'd like to thank Natera for inviting me to moderate the session and also give a talk. The title of the talk today, the Lunch Symposium, is a molecular level insights in transplant care, Prospera deep dive. There will be a talk today. I'll be the first speaker. And my name is Mike Bunapradest. I'm a transplant nephrologist and professor of medicine at UCLA. I'll be going over personalized care with Prospera. Dr. Mohan, who will talk about longitudinal monitoring of anti-rejection therapy using Prospera and background cell-free DNA. Then we'll follow with the live Q&A session. My first talk is personalized care with Prospera. So first, let me show you the natural history of the cell-free DNA in the last 50 years. It was first discovered in 1948 by Mandel and Metals. They can detect the cell-free DNA in human blood. In 1997, Lowe et al. Were able to identify fetal cell-free DNA in pregnant women that, after 14 more years, led to the first commercially available prenatal diagnostic tests for detection of abnormal chromosome using fetal cell-free DNA technology. In the next several years, the focus has been to use in the oncology field, with the first detection of cell-free tumor DNA, which led to the utilization of the technology in delivering of the target therapy using the next generation sequence technique. So let's first talk about what is a cell-free DNA. So this cartoon shows you this is the cells. When the cells undergo apoptosis, which is a normal turnover of the cells, the DNA would then leak into the bloodstream. And this DNA would then chop into multiple pieces. Besides from the apoptosis, the cell-free DNA could be generated by the necrosis, which is pathological breakdown of the cells, and even from the secretion of the DNA from the cells into the bloodstream. So the nature of the cell-free DNA is highly fragmented, double-stranded DNA. It's fragmented because it got cleaved at multiple sites. The usual size of the cell-free DNA is about 150 to 167 base pair if this is through the apoptosis. And the fragmentation pattern could also be helpful to say where the DNA was coming from, with which tissue. If it's a necrosis, it's usually more random and larger fragmented insides, and you can tell whether it is a necrosis or the apoptosis. After the cell got breakdown, DNA got leaked, you can find the cell-free DNA in plasma, in blood, in the CSF fluid. It has a very short half-life, 30 to 90 minutes, therefore it reflects a real-time biological activity. And one of the most important things for a nephrologist is we don't understand fully how the cell-free DNA got metabolized, but it's not affected by the renal function. So it doesn't matter if you have good or bad renal function, the half-life is not affected by the kidney function. So this slide shows you how the Prospera test work. So when the company received the blood sample in the test tube from the transplant patient, we know that blood would contain the mix between the donor and the recipient cell-free DNA. They used a precise detection looking at more than 13,000 single nucleotide polymorphism, or the SNP, to differentiate between donor, seen here in blue, and the recipient in green, and tell which and how much of those are from the donor and from the recipient. When they get the test result, they will look at the percentage or the proportion of the cell-free DNA. The normal one shown in the upper row here, which is very small portion of the donor DNA in the whole total DNA. If there are rejection, the active rejection, you would expect to see more blue, more donor DNA, cell-free DNA. And the cutoff that we use to report the result is 1% and higher to say whether it is a high risk or low risk result. Suffice to say, in order for the labs to do that, they would have to have a very powerful DNA extraction. They have then to prepare the cell-free DNA from the library, looking at all these genes, and use AI technology, bioinformatics, to come up and call which one is self or non-self, and report to us as a percentage of the cell-free DNA. With that background of how the cell-free DNA, the Prospera test was done, I would like to show you some of newer data. This data was presented at the ASTS winter meeting last month. The title is Assessment of Donor-Derived Cell-Free DNA for Allograft and its Detection into Clinical Practice. I would like to show the result of the 28 high-risk patients defined by donor-derived cell-free DNA fraction more than 1%, who had a definite biopsy within the 2 weeks of the test result. We can see here in the pie graph, first is a third of the patients show no active rejection. 28% show T-cell rejection in the blue color with varying grade of the rejection, 1A, 1B, 2A, 2B. 21% had pure ABMR, and 14% had mix of the T-cell and the ABMR. Among those 10 patients that had no active rejection, 6 out of 10 show other pathological findings, including glomerulonephritis, diabetic changes, diffuse necrosis, ATN, lupus nephritis, and borderline rejection, and only 4 out of 28 had no significant pathological finding. So this slide shows you the median cell-free DNA according to rejection type in figure 3, and on the figure 4, we'll talk about the timing post-transplant. So on figure 3, we break the rejection into 4 groups, ABMR group in yellow, TCMR, the mix, and the non-rejection, and correlated with the level of cell-free DNA. As you can see here, the Prospera are able to detect the rejection with high cell-free DNA in ABMR group, the T-cell mediated rejection group, and the mixed group, and this is the result of the non-rejector here. When we look at the timing post-transplant according to the type of rejection, we can see that the T-cell in this cohort occur quite early in the first 3 to 5 months compared to the ABMR group, which usually occur later at about 9 months post-transplant. The study results indicate that the adoption of routine donor-derived cell-free DNA testing to clinical care may lead to a more judicious use of allograft biopsy, both to biopsy and not to biopsy. And to summarize, analysis of real-world data revealed donor-derived cell-free DNA testing provided a 64% rejection positive rate among biopsy ordered by physician in those with positive derived donor cell-free DNA. And this 64% rejection positive rate is considerably higher rate than other rejection biomarker and superior to what is described in previously published validation study in population average risk for rejection. So next, I would like to introduce Dr. Prince Mohan. Dr. Mohan is a transplant nephrologist and medical director of Kidney and Pancreas Transplant Program at Geisinger Health System. He has clinical research interest in BK virus, post-transplant malignancy, living donation, and immunosuppression. His research interests include post-transplant outcome, public policy, and organ discard rates. Take it away, Dr. Mohan.
I want to thank Natera for giving me the opportunity to present at this symposium. The purpose of this symposium is to go over cell-free DNA, test Prospera, and to find out where we can have little small things that will give us better understanding of this test. Cell-free DNA is being used in all the centers across the country. And after this presentation, you should be able to get a little better understanding, or a lot better understanding, of how to interpret the results when the results are not consistently what you are expecting them to be. The results of the tests are given as a percentage between the cell-free DNA, or also known as background DNA, and the donor-derived DNA. So depending on what or how much background DNA or cell-free DNA is what I'm going to call it, it can skew the results of your percentage of the test that will be given. So as we all know, if the cell-free DNA, in this case, Natera Prospera's results are more than 1%, the test is considered positive. That means there is a injury that is happening to the allograft. and we have to find out what is the reason of that injury, whether that injury is rejection, whether that injury is related to a viral infection or just a bacterial infection like UTI. So it is very important that we understand that what can skew the results, make it higher than 1% when it is actually not, or make it lower than 1% when it actually is higher. So if we understand this, it will remove the chances of false negatives and false positives that we tend to see. There are many factors that can influence the background DNA. High body mass index is one of those, sepsis, age, if you had a surgery, or how long the sample has been sitting. If you had recent chemotherapy, there are some normal variations that happen among us. Myocardial infarction, hemodialysis, rejection, all those things can influence your background DNA. When we are doing a cell-free DNA test, Prospera in our case, everybody knows that we should not get Prospera done immediately after biopsy, because we understand that we have done a procedure and that's going to increase artificially, so to speak, the donor-derived cell-free DNA, and that can lead to a false positive test for us. In the same way, if a person has received chemotherapy, and in the case of transplant, that could be bortezomib if you have used for rejection, that could be the use of CD20 and monoclonal antibodies that you have used. Those can sometimes increase your cell-free DNA, or what is known as the background DNA. And what that would do is that would decrease the percentage that's going to come back, and it might give you a false negative test. So these are the things that you need to understand, that when the test is being done, you have to know if there is anything else that has been done with the patient, i.e. if they have received a strong anti-rejection medication, if they were septic, if they have a UTI, if they were given antibiotics, all those things come into play. And sometimes it is important to see if there are significant variations that are happening. And as we go over the test, over this presentation, we'll find further. As we were discussing in the last slide, there are many factors that can influence the baseline or the background cell-free DNA, so to speak. I want to go out and look at the few examples that you have here. We have a pregnancy, we have kidney transplant, and early stage cancer. What you see here is that in pregnant female, the extreme outliers are very rare. So that means a healthy pregnant female, you're not going to see much of variation. Whereas if you're looking at in kidney transplant patients, you will see there is higher percentage of patients who have high background cell-free DNA. So variability of cell-free DNA, rejection specifically, we can see here where you have got stable patients, you have got patient with ATN, you have patient who has got calcineurin toxicity, you have got infection, and you've got acute rejection. Interestingly enough, in this chart, you will see that patients who are stable transplant patients, their cell-free DNA, the donor-derived cell-free DNA, is pretty stable. It stays very, very low. But as you go from ATN to calcineurin inhibitors and infection, and then you look at acute rejection, the cell-free DNA, that is donor-derived cell-free DNA, just keeps on going up steadily. And the highest range is seen in acute rejection. But I want everybody to pay a little bit of attention here, that you see in infection and acute rejection, there is an overlap, which is very important. And we have seen in practice that if you have a patient who has an infection, which is not just a cystitis, but actually kidney is involved in that infection, then you will see a higher cell-free DNA. That's why it is very important to remember that Prospera is not just a test for rejection. It is a marker of injury. So if your Prospera is more than 1%, you have to stop and think that, is it a rejection that's happening versus it's BK, or it's just an infection that is increasing the cell-free DNA? These are very important things, and we should always look at it. The paper here is from 2009, and it is quoted here. The next one is an abstract that was presented, and I want to go over this example that we have here of my patient that I took care of, and that will elaborate exactly what I was explaining as to what happens when a patient gets CD20 antibodies and how it affects their cell-free DNA. So whatever I'm going to tell now is nothing new. We know it from before. We did discuss it a little bit earlier. So we start the immunosuppression medications for our patients to make sure they don't reject. The purpose of immunosuppressive medications, we give them what is known as the induction therapy and then the maintenance therapy. And then we check on a regular basis the cell-free DNA to make sure if there is any injury that is happening to the allograft. And elevated ddCF DNA, which is donor-derived cell-free DNA, will give us the percentage of it will give us it's a marker that will tell us if there is an injury that's happening. And as we discussed earlier, there are multiple factors that can alter or that can change the percentage of this donor-derived cell-free DNA, and we have to stop and think as to what is going on. So we're looking at this case. The patient had antibody-mediated rejection. It was a biopsy-confirmed rejection, and he had cell-free DNA and Prospera done at multiple points. And we looked at how this percentage changed over time, and then we had to look back and find out when the patient got rituximab and how it affected the change of Prospera. So this is a 52-year-old guy who was transplanted in 2016. His transplant was done a little before I came to the program. He was maintained on a triple therapy regimen. This guy did have an eventful post-transplant part where he ended up having a large stone that obstructed his kidney. He had to go to OR and get that fixed, but later on his creatinine came down to 1.4 to 1.6. He was doing extremely well. 4 years after transplant, he comes up and his creatinine has gone up to 2 milligram per deciliter at this point. Of course, we were worried as to what's going on. So we did the biopsy, and biopsy did show there was acute antibody-mediated rejection with moderate transplant glomerulopathy. So what we will call now as a chronic active ABMR. And as any other center will treat the person, we started patients on plasmapheresis. We gave him IVIG, the regular doses that were required. He was given rituximab, 1 gram in total, and 2 doses were given. And at regular intervals, we were getting his Prospera test done to see how his Prospera is going up or down, as we know that Prospera can be used to monitor the response to therapy. And we can see here, patient had ABMR, we did a biopsy, he got IVIG, he got rituximab, and we did a cell-free DNA, which was 4.67%, and we know this is pretty high. And then we look at his total cell-free DNA, which is 0.87 millimolar. So he gets another IVIG here, he gets another dose of rituximab. We get a cell-free DNA back on him as things are happening, and his Prospera results come down to 0.64. But if you look at his total cell-free DNA, his total cell-free DNA here is significantly higher. But his creatinine was going up, so we did a biopsy on him, unfortunately disregarding, or fortunately disregarding the results of Prospera, and we found out that he was still having ongoing rejection. So he was treated again, and he got another dose of rituximab and the rest of the therapies, and we repeated his Prospera test. It came back to 2.25%. And then again, once again, he got his cell-free DNA, and his Prospera results were 14.73%. So if you look at all these different time points, what you realize is that the Prospera results are going from one end of the spectrum, which is 0.64%, to the extreme of 14.74%. So I want to dive a little bit deeper into what is happening with the percentage that we look at, 1%, 2%, 3%, or less than 1%, and total cell-free DNA, which is here in orange, and then the donor-derived cell-free DNA, which is here in a nice shade of green. As you know, men don't know color, so we go with green, blue, red. So for me, that is green. If my daughters were here, they would tell you exact color. So if we look here, the donor cell-free DNA the percentage was given as 4.7%, and cutoff, as we all know, is 1%. So the cutoff here is low, here is high, and here we know that there is some something happening, whether that something is infection or rejection or whatever else have you. But in this case, we know it is antibody-mediated rejection because we have the biopsy that shows us what's going on. Now, if you look at the total cell-free DNA levels here, you can see that in test 1, the levels were completely okay. So so to speak, that they were within the median range. If you look at test 2 now, the total cell-free DNA is extremely high. It is 12 times the normal. So if you have total cell-free DNA, which is 12 times normal, it is going to skew the results because your denominator has changed and your numerator has not. So that's going to skew the results. And if you look at the test 3, your total cell-free DNA is still a little bit higher than median, but not that high. That will skew the results significantly. And in test 4, your cell-free DNA is very, very low here. So what is the reasoning behind it? What is going on? So it is very important to understand, when did we get this test done? Did we get the test done when the patient just received his rituximab? If the patient just received the rituximab and the test was done within a couple of days, you know there's going to be a large influx of cell-free DNA that's going to happen from the B cells that are being killed. Are you getting the test just after the patient had plasmapheresis? Because guess what? If plasma is being removed, you might be removing some cell-free DNA as well. And if you just got the test done right after plasmapheresis for some reason, that might skew the results as well. The half-life of cell-free DNA is about 6 hours, as we all know. Not cleared by kidney, but regardless, the half-life is 6 hours. And when you are getting the plasmapheresis done, it is going to remove a lot of the cell-free DNA as well. And you have to know these things, and what else is being done, so that when you look at the results, significantly changing results, that means like here, where it's 4.6%, and then it's gone to 0.64%, it's gone to 2.25%. So you have to look at these things and take them into context and ask your MSL and ask them, hey, can you please tell me what is the total cell-free DNA here? And then look at whether they are in the median range or they are really big outliers. That means the test results that you're looking at are not very accurate, and you have to stop and think and then take the result with a grain of salt. So in conclusion, if I have to summarize the whole thing that we discussed, donor-derived cell-free DNA is a good test. It gives us a range of things that we can look at and say, hey, you know, what's going on? It makes you stop and think about what's happening with your patient. It is not a test that you can just use one time and then call it a day. It is a serial test. That means if today's result is 0.5%, tomorrow's result is 1%, and 1.5%, you know it is going in the wrong direction. You can stop and think and look at if the patient is taking immunosuppression or the patient is not taking immunosuppression, or if the patient's PK is going up. These things can be looked at. If patient cell-free DNA is constantly stable, you know that things are okay. After rejection, if the levels start going down, that means, you know, most likely the injury has gone down. So, but you will see there will be some outliers, and these outliers are going to become more important when you are treating patients for rejection, where you're giving them CD20 antibodies, where if you're using bortezomib, if you're doing plasmapheresis. So it is important to keep a note of when the test is being done, so that you can go back and look at it like, oh, you know, plasmapheresis was done. Did patient get their test after plasmapheresis? Did the patient just get their cell-free DNA drawn a day after they had CD20 or bortezomib done? Things like that. So when you're looking at this, it is not a test that you're going to look at one time. It is a test that is a serial test that will tell you what is going on with the patient. You have to look at the total cell-free DNA because it can confound the interpretation, or it can change the interpretation what it should be. And you should always look at if there is a rejection, or if it is related to BK, or if it is related to infection. Ask your MSL to find out what was the background cell-free DNA, so that you can understand the results of it and compare the prior results to the current results and look at the cell-free DNA, so that you are not going to do something which is not appropriate for patient care. I want to thank everybody for staying back and listening to my talk and attending this presentation. After this presentation, we have a montage of my colleagues who have used Prospera cell-free DNA in the transplant setting, both for surveillance and for active rejection purposes. After the montage, we will have a Q&A, live Q&A for you guys. So please do stay and ask us if you have any questions, and we'll be very happy to answer any concerns that you have. And thank you again.
So I'm the medical director of kidney transplant at University of Cincinnati Medical Center. For every biopsy decision, then one has to think twice whether it really needs to be done and what's the urgency of it. And just for example, given current COVID situation now, to get a biopsy done within the hospital, all these patients also need a COVID testing before they can come into the procedure room, which adds another visit for the patient, another layer to delaying the process, because then they have to do the test and then get the test back result, and then they can have the biopsy performed. The other situation that we commonly encounter is someone who has opportunistic infection, whether it be BK virus viremia or CMV infection, or any time when people have adverse reaction to immunosuppressive medication. So it helps optimize immunosuppressive therapy. Time and again, we have patients who come to our clinic where their immunosuppression medications have to be brought down, which makes all of us uncomfortable. And in the past, we've always just been using one size fits all, and with targeted medicine, with targeted therapeutic levels, we still don't know what the level of immunosuppression is when we deliver 2-3 medications at the same time. So this technology helps us at least monitor for rejection or any adversity that may happen when we change these immunosuppressive doses too fast or follow them along with in due course of time. We have a big group of transplant nephrologists along with nurse practitioners and fellows, and as a group we provide pre and post transplant care to these patients. The biopsy itself is an invasive procedure, which means that the patient choice, patient characteristics do play a role in the degree of complications that one may encounter. So body habitus is one where body type may put them at a higher risk for bleeding and complications. Many a times the way the kidney is placed, so most of the kidneys are placed extraperitoneally. So Prospera or cell-free DNA testing helps a clinician make that judgment better without needing a biopsy for every clinical kidney dysfunction. Especially with using Prospera with the high negative predictive value, where we can confidently say that yes, if the test is negative, the likelihood of rejection is very, very low. That itself gives us strength to the patient and to what we tell them. So we recently had a patient who was in his mid-40s, got a kidney transplant 2 months back, who happened to get a good kidney with a KDPI of 60. The creatinine sort of settled down at 1.8, 1.9 as a baseline. I would have been happier with a creatinine of 1.4, 1.5. So we were not at ease that this is a comfortable place to settle down. But then he comes back, his creatinine jumps up to 2.4. And this is where Prospera testing came to our help for our clinical judgment. And we decided to just do the test and let the patient go. And the test came back negative, which was reassuring for us and for the patient. And a repeat creatinine few days later came down to 1.9, which again was where he was. So it just avoided unnecessary admission to the process.
My name is Sanjeev Akina. I'm a transplant nephrologist at Loyola University Medical Center in Maywood, Illinois, just outside of Chicago. So approximately 2 months ago, I was on call and I received a call from a nephrologist at an outside hospital. He called about a patient that we had transplanted about 2 years ago. And he said the patient came in and was diagnosed with a CNS lymphoma, or a post-transplant lymphoproliferative disorder. So he was asking for our recommendations on what to do for management of this patient. What we immediately advised him to do is to go ahead and take him off one of his, we asked him to take him off his Myfortic. So he was on a 3-drug regimen, Prograf or tacrolimus, mycophenolate, and prednisone. We immediately suggested to stop the mycophenolate and to just continue with Prograf and prednisone. He then went we then advised him to continue with his oncologist for the management of his post-transplant lymphoproliferative disorder, primarily because of his location. He was someone that had difficulty coming back to our center for follow-up visits, and we felt it was best if he could just maintain his care at a hospital close to him that we felt actually had pretty adequate resources to be able to manage his PTLD. So with that reduction in immunosuppression, he underwent chemotherapy and was treated with methotrexate and rituximab for 9 cycles. And then he underwent follow-up, and it was found that his tumor was actually stable. There was no progression of his disease, and they felt like he was responding well to therapy. However, COVID hit, and then he kind of disappeared for about 6 months, staying at home the whole time. He then represented to the hospital in September with the symptoms of lower extremity swelling, where he felt like he was in kidney failure or symptoms similar to kidney failure that he had many years ago. So he came in with that concern of lower extremity edema and was found to have an elevated creatinine of 1.9. So I got another call from this transplant nephrologist saying, hey, this guy's creatinine's elevated. What would you like us to do in this case? Because obviously our concern was rejection. He had a tacrolimus level that was within the therapeutic range. He had a renal ultrasound that was normal with no evidence of hydronephrosis or any type of obstruction. And so other tests that were unremarkable. They were not able to get BK PCR testing, so we didn't have that answer immediately. But I said, with the concern for rejection, I think it was reasonable to do a biopsy. Again, because of transportation issues, and he was already at the hospital over there, we felt go ahead and proceed on with the renal biopsy at the center. He had a renal biopsy done, and unfortunately, it came back non-diagnostic, as it was mostly medulla on the biopsy read. So they were not able to make a diagnostic, or they were unable to make a diagnosis based on the biopsy. So then they called us and told us that, we're unable to find it or give you a diagnosis at this point. What do you think about trying to have the patient come over to our center? Again, with the same issue that he was unlikely to be able to come back to our center for multiple reasons. We thought, well, maybe the next thing we should do is creatinine remained relatively stable during his hospitalization, and he looked stable. We said, well, why don't we try to do lab testing? And we thought, well, what might be the best option would be trying a cell-free DNA option. So we were able to arrange for him to get a Prospera test and regular labs at his house through the ProReach program at Natera. So the phlebotomist was able to go over there, draw the Prospera test, a basic metabolic panel, and CBC. We were unfortunately unable to get a Prograph level or BK PCR at the time, but we were able to get enough information at least to start with. Then the results came back. His creatinine was a little better at 1.6 compared to the 1.9 he had in the hospital. And more importantly, his Prospera actually came back negative at less than 0.08. So from our experience in using cell-free DNA testing and with Prospera in this case, we find that having this high negative predictive value is very helpful in trying to rule out cases. I think there's also some benefit in using these cell-free DNA technologies also as a longitudinal case, where you're trying to use this as a monitoring tool along with the serum creatinine, especially if they're like 1 or 2 years out after transplant. Because I think, you want to try to capture a lot of those subclinical rejections as early as possible. And I think this is where it can be very useful. But the question is, how can you improve long-term outcomes, 5 years, 10 years out? And that's where I think Prospera testing can be very helpful in detecting subclinical injury before you notice significant changes in your serum creatinine. And that's where I think if you can improve the long-term allograft function, I think that's where you will actually have much better outcomes and less kidney transplants or less need for retransplanting patients and a better quality of life.
I'm Wayne Kotzker. I am a practicing nephrologist with Florida Kidney Physicians. I am based mostly in Boca Raton, Florida. I have 54 partners throughout the state. We practice general clinical nephrology. So within the last few months, I've become aware of Natera and the ability to use Prospera to monitor renal transplant patients. And I've introduced it to a number of my patients as a way of an earlier detection for possible rejection and a way to give an added tool to monitor their post-transplant course. The ProReach program is a program that provides mobile phlebotomy to draw the Prospera lab, but it also allows for the complete labs to be drawn. So the patient is only stuck once, which is another benefit for a patient who's going to frequent labs to be able to get the Prospera test and their complete transplant profile at the same time, including their drug levels, their serum creatinine, and even some of the other routine tests that we get on a transplant patient on a regular basis. I've had one patient who the marker was, positive or equivocal, and being able to refer them back to the transplant center earlier than having to wait for their annual visit is also valuable, because in a case they did not opt to do a biopsy, but at least the patient was able to have a conversation with the transplant nephrologist and be able to get the reassurance they need regarding their transplant care.
My name is Prince Mohan. I'm the medical director of kidney transplant at Geisinger Medical Center. So there are some cases where I would have done a biopsy, but I did not. I have a patient, which is a very interesting patient. He's a young guy in his late 30s who got transplanted. He had recurrent FSGS within a week of his transplant. And after transplant, we biopsied him. He had FSGS. His creatinine ranged in mid-2s, and it went up to 2.9, and I really got worried that there is something going on. We got serial Prosperas. They were all negative. So I didn't biopsy that patient because I knew that this is not related to a rejection type of thing. It is something else that's happening with this gentleman. And bringing the patient right now in the setting of this pandemic to the hospital was not the best of the things. So Prospera gave me this confidence that I don't need to biopsy the patient and that I'm managing the patient properly. Another important point is it is not just a one-point test. It is a serial test. That means you're doing it every month. And if every month you see it was 0.12, it has gone up to 3.6, it has gone up to 2.7 now, you have to stop and think and find out what's going on. So I don't think it's another test. I think it's a test that has value, and it adds value for patient care, for patient satisfaction, for physician satisfaction as well, because if you have to bring a patient in for biopsies is not a very benign procedure at times, because if you have got a patient who is obese, patient who is on anticoagulation, you have to stop anticoagulation, you have to send them to Coumadin clinic. If you have one, you have to bridge them to other methods of anticoagulation. So it can be sometimes a very cumbersome procedure. So if you have this test which can tell you, you know what, the chance that there is no rejection is 95%, I don't have to biopsy that patient, and that is important. It is not just another test. I think it's a valuable test. This test, important thing is it has to be done 4 weeks after the transplant. We usually say wait for 4 weeks. And after that, we do it once a month for about 6 months, and then you can do it quarterly. So it is not a test that is done every week. You have to remember that early post-transplant patients are getting a lot of blood work done. Patients can actually get their blood drawn at their own home. So they don't even need to go to the lab in the hospital. There is a mobile phlebotomy that will go to their place. They will draw the Prospera test. It is convenience for them as well. For stable patients, if you're wondering about where you're going to use this test, if a patient is coming out of transplant center and coming to you, if it's a stable patient, you can get it every 3 months and you can be sure things are okay. It gives you a confidence about what's going on with the patient. You can get their Prospera when they enter your clinic, and you will have a baseline Prospera and you'll have the baseline creatinine. I get good service from them. I get a call back if my patient has any issues, and the results come back in time, and I have the portal where I can access the results.
So without the presentation, I would like to open up the session for the live Q&A. Thank you. All right, welcome back everyone. And I hope you enjoyed the talk for the first 40 minutes. And with all those information, we are opening up for the Q&A. We have several questions already from the audience, and others, please feel free to put in the question and answer. So let me start with the first question from Dr. Brian Valeria. The question is, would the examination of methylated DNA, typical of kidney origin, rather than only total donor background cell-free DNA, permit more accurate identification of increased donor-derived cell-free DNA, specifically damage to the kidney. I guess the question is, can we be more specific of where the DNA is coming from? My understanding is the methylation of the DNA is to all the DNA in the body, not specific to the kidney. There are data that show that people with kidney disease have more methylation of the DNA. When we check the DNA in the blood, the technology from the company can actually differentiate between the donor and the recipient or total DNA. And all the donor DNA are coming from the kidney if we are looking at doing the test in kidney transplant patients. So I'm not sure if by doing methylated one for the kidney would actually be helpful on this. Dr. Mohan, you have anything to add on that?
So I agree with you 100%. The thing is that methylated DNA, we have been working on it for, when I say we, our researchers have been working on it for a very long time. Methylated DNA is part of an epigenetic phenomenon where we think that the environmental factors are affecting the DNA and how things are happening. So we know that methylated DNA is increased in CKD. It is increased with ischemia reperfusion injury and in kidney transplant. Also with the in rejection, or when we have got the HLA class 2, which is increased, that is also, when you see that, actually the methylated DNA is also increased. So it's a urinary marker that you're essentially going to look at, that how much of methylated DNA you have. Whether it's going to be specific to the donor or not, I'm not clear about that. As Mike mentioned earlier, that all the DNA gets methylated. Yes, if you look at an urine, then you're sure that it is most likely coming from kidney. There are some genes that have been looked at specifically for albuminuria and things like that. And in kidney transplant, the CALCA gene has been looked at as well. So while it can be useful, but I don't think we are in the era where we can say, yes, it is going to go live. It is still in the research phase, so to speak.
Great. So the second question is from Dr. Palak Char. The question is, does the half-life of cell-free DNA level vary by organ type? The answer is no. The background cell-free DNA lasts about 30 to 60 minutes. I think depending on how large the fragment is and how it gets metabolized. The way the cell-free DNA is metabolized is largely unknown, but most importantly, it's not affected by the kidney function. So it's not going to last longer because your kidney is not working. So that's probably one of the things that we would take that in mind. So the next question is from Dr. Melissa McGovern. The question is, how quickly does cell-free DNA change in response to treatment? Do we know the half-life of cell-free DNA to know when a repeat Prospera test would be appropriate in order to considering cost to the patient? What value does this add compared to a repeat biopsy? Or would you use it in place of repeat biopsy after treatment for AMR and TCR? I'll answer that first, and I'd like Dr. Mohan to also put in his clinical experience. So as I just told you, the half-life of cell-free DNA is 30 to 60 minutes. So it's a very acute phase marker. So you check the next 60 minutes, then you probably can tell what's actually going on in terms of the cell-free DNA. The second question, though, more importantly, is how long does it take before the treatment response happen before we should check another one, right? It's the same thing that, we don't check creatinine every few hours. We check it every day or such. So there is an ongoing study by the Natera company. The study is called PEDAL, which basically looking at the cell-free DNA testing at the time of the biopsy. And if the patient have a rejection, they would repeat the test every 2 weeks for the next 6 weeks. And that would be helping us to look at the response to the treatment using the cell-free DNA. My practice is to check it 2 weeks and then 6 weeks after to make sure that the active injury, active rejection is gone, demonstrated by the return of the background cell-free DNA back to normal. In my practice, I usually don't repeat biopsy unless creatinine come down to baseline. And in most of the cases that the creatinine come nearly to the baseline of cell-free DNA back to normal, I probably would not biopsy patient again. Dr. Mohan, how would you do it?
I agree with you again. You're on the ball here, that if the cell-free DNA has come down to a baseline level, that means it is way less than wherever it started at. It. If you heard the case earlier, the patient's level was up 3, and then you recheck it after 2 weeks and the level is 0.5, you know that the level has decreased significantly and the creatinine has come down to where it started. At that point, it gives you this confidence that things are better. Now, if the creatinine is not back at baseline in 2 weeks, or you're checking your cell-free DNA and it was 2.5%, it's still 2%. At that point, you have to stop and check the biopsy just to make sure whether you have an adequate response or there is something else going on that you did not catch on your first biopsy. But otherwise, yes, if your creatinine has come back to baseline, if your cell-free DNA level has come down significantly, then you can be at peace that things are going in the right direction.
Right, and I think the company is still looking for center, I believe, for the PEDAL study that basically would be answer some of those questions, how the DNA changed after the rejection. So if you like to contribute, please contact your MSL to see whether you could be in the study. Okay, so I have several more questions. This is exciting. I see people are getting excited about the test. So one of the questions from Christina Lee from USC. So will total cell-free DNA be released on results in the future? And the answer is, at this point, as of now, let's talk about now first. When the company report the cell-free DNA result, they always look at the background number of cell-free DNA to the median healthy patient or kidney transplant patient. The background in normal patients is around 2,000. So the background cell-free DNA go up many-fold, and that would affect the ratio of the donor-derived and the total cell-free DNA. That result would be flagged, and then that result would be communicated. And if you like, there's many ways for the company to communicate with you. You can have a default that the MSL would call you when the result is abnormal to discuss further with you, or they can just flag and then you can make a decision of what you want to do. We didn't talk about that today. We had a case that is in press for Transplant Direct, looking at the background cell-free DNA in patient with COVID. And in that patient, the background cell-free DNA went up more than 10 times, causing the ratio of the donor-derived to be very, very low for a long time. And when the COVID infection improved in my patient, that patient was was AKI, multi-organ failure. And when she started recovering, the total background cell-free DNA coming down and donor-derived cell-free DNA stay constant. The patient didn't have a rejection. We didn't treat patient for rejection. The patient recovered from the AKI. And then, so that's one way of looking at how this background cell-free DNA would impact the interpretation of the result. Dr. Mohan, you have any of those that you get called for higher background cell-free DNA?
So we had a couple of patients who had higher cell-free DNA, and the company will give us a call like, hey, the person has higher cell-free DNA. Usually it happens in a patient in whom they have either some rheumatological disorder or something else that's happening. You just gave them rituximab, as you saw in the study that I was discussing, and the patient that I was discussing earlier. So if they just got rituximab, it's going to cause a huge cell lysis and some other effects as well. So that can cause some small, increase, and you have to be cognizant of that. And just a couple of patients is where we have seen this. But if something like that happens, your local rep will give you a call and they will tell you what's going on. And then you have to take into consideration what else is happening in the patient's condition, as we discussed in the case report earlier.
Great. Another follow-up question from the audience was, could a high background cell-free DNA level lead to a false negative test? If so, does Natera report when the background is high? Dr. Mohan, you want to take that question?
Yeah, so as just was explained like a few minutes ago by Mike, the fact is that if your background cell-free DNA, that is your own cell-free DNA, is higher, then of course it's going to affect the results. And yes, the company will tell you that there is a higher level, and you might have to take into consideration that this is a false negative test, as we were just discussing earlier.
Very good. And this is the area that the company, I understand, is still doing research on with other studies they're doing. This is more likely true in the case that the cell-free DNA result is just a little bit lower than 1 or a little bit higher than 1. So the total background cell-free DNA may have to be taken into account to interpret those results as well. The next question is, Are there any differences between interpretation of result for pediatric versus adult patient? What about sex-based differences? So there are no sex-based differences for the background for the interpretation of the Prospera test. The use of in pediatric patient is still under study. So if you want to do tests in pediatric patient, we would recommend reaching out to the company so they can evaluate the use in your particular patient and see what they can do to help interpret the result. The next question is from Dr. Vega. Maybe I ask Dr. Mahan, how many of your patients with a positive donor-derived cell-free DNA result has a proven kidney rejection? So talking about false positive, false negative.
Yeah, so false negative, you will see. So once you see the high cell-free DNA, there's one thing that I want to put it out there, that does not mean rejection. That's not the first thing that should come to your mind. It should just mean that there is an injury that is happening to the allograft. Now, what is causing that injury? Before you go ahead and take your needle and take to the kidney, you have to stop and think and find out, okay, what else is going on? If there is a significant UTI going on, does this patient have BK viremia and things like that? So when you will see a false negative test, most of the time, and I have seen it, I have been on the side where I did a biopsy and found out later on the patient had a UTI, or, by the time we brought the patient in and we found out the patient has UTI. So false negative rates will be, so before you interpret the test, just blindly take a look at the patient, take a look at the scenario, and then you will see that your false negative, quote unquote, false negatives are actually not false negative, but it's just an injury. If you will realize that this is an injury mechanism rather than always an allograft rejection mechanism, then you will realize there is no false negative. Actually, it's just telling you that, hey, there is actually injury happening, whether that is related to rejection or it's related to BK infection or it is related to a pyelonephritis that's happening. I hope that answers your question.
Great. So let's see, are there any other questions from the audience? I can also answer that question about how many of my patients have rejection or not. There were a few of my patients that did not have an active rejection, but they have some other thing going on, but that's small amount of patients. One of the patients that I had was the patient who had AKI, and we did the ultrasound, and the ultrasound showed questionable renal artery stenosis. So we went on to do angiogram because patient couldn't have the MRI done because of the medical condition. And they did the angioplasty of the lesion. We checked background cell-free DNA within a week after it was high. And the biopsy showed no rejection. I was questioning whether or not it was the injury to the blood vessel of the donor at the time of the angioplasty that actually caused the background cell-free, caused the donor-derived cell-free DNA to go up. And it repeatedly came down without any treatment. So that was the one that has so-called, I'm not sure, false positive, but probably could be explained by the injury to the kidney by the angiogram.
There was this question about if there is any sex-based differences. It's very interesting that the first time we used, or not, the chromosomes were used to, or genetics was used to find out kidney injury was based on if there was a mismatch of male and female. So if a male got a female kidney, then they will have this Y chromosome. So if the Y chromosome is higher in the blood, that's how they found out there is rejection. But this is going back many, many years. If I remember correctly, the paper was out from either Hong Kong or Singapore. So 1970s. But for cell-free DNA, there is no difference.
Right. I think that was from the Hong Kong group. All
Yes.
right. With that, I think we have a really interactive and wonderful discussion from the speakers. As a moderator, I want to thank everyone. I also would like to thank Natera. Also would want to say that this recording will again be rebroadcast, including the Q&A on the AST website. So good luck to everyone and enjoy the rest of the meeting. Thank you.
Thank you so much, Mike. Thank you for moderating the talk. Much appreciated.
Bye-bye.
Bye-bye.